All of us know that this is the spectrum of coronary artery disease from acute to chronic, and sudden cardiac arrest due to ventricular tachyarrhythmias can occur at any stage. It can occur due to acute ischemia, acute myocardial infarction, or scar-related remodeled dilated LV. So sudden cardiac death can occur any point of time. What we have to remember, the first figure, 48 hours. When we are talking about ventricular tachyarrhythmias, less than 48 hours post-MI, this is early ventricular tachycardia or ventricular fibrillation. We call it primary VT or VF. Beyond 48 hours, it's VT-VF or secondary VT-VF. The mechanism of both are different. So this is something you have to understand. Before 48 hours post-MI and beyond 48 hours post-MI. Primary VT occurs in first 48 hours period after MI, and acute ischemia is directly responsible. And patients will get polymorphic VT of this type. Immediate life-threatening issues need to be managed optimally. Otherwise, this can cause sudden cardiac death. We all know sudden cardiac death may be the first presentation of coronary artery disease in almost 40% of the patients. So, Gusto trial we've all heard of. This was published in 95, 40,000 patients. Approximately 10% of the patients had ventricular tachyarrhythmias, 3% VT, 4% VF, and another 3% both VT and VF. And ventricular fibrillation, as we all know, is a giant killer. In this trial, it was found that patients who had both VT and VF, early VT and VF, the 1-year mortality was almost 50%. This was much, much worse compared to those patients who did not have these arrhythmias in the early period, where the survival was almost 95%. Those patients who had either VT or VF, it was intermediate. And most of the, as we saw, the VF and VT occurring early, the first month was the most dangerous. In fact, the in-hospital mortality rate for patients with only sustained VT, 18%, but with both VT and VF, almost 44%. Patients with sustained VT or both VT and VF who survived to 30 days had a higher 1-year mortality compared to those who did not have VT-VF. And long-term outcome, as you know, is affected. 11 years down the line, Gusto 5 trial with retiplase, again, early VT-VF defined as within 48 hours after MI, occurred in about 4% of patients, and 30-day mortality and 1-year mortality was higher compared to those patients who did not have early VT-VF. In the current era, when we are doing PCIs for acute MI, those patients in whom TIMI grade 3 flow was not established, late VT-VF, the mortality was much more compared to those who had grade 3 TIMI flow. But even in them, you have a clue as clinicians. If the ST resolution is less than 70%, then it is even worse. So 90-day mortality related to post-MI VT-VF, if it is late, almost 33%. Much, 10 times worse than those patients who did not experience these ventricular arrhythmias. And early VT-VF, that is within 48 hours after MI, it was intermediate. So all patients who are post-MI, who do not have VT-VF, have obviously much better prognosis. But the worst prognosis is those who are having late VT-VF beyond 48 hours. Several studies have been done and several risk factors have been found which can predict what predicts these mortality in these patients. So for early ventricular tachycardia, ventricular fibrillation, what are the risk factors? Pre-PCI TIMI flow grade 0. Larger the ST deviation, more is the risk. Low creatinine clearance, inferior MI, Killip class, patient in heart failure, or resting tachycardia. Whereas for late VT-VF, if the ST resolution is less than 70%, resting tachycardia, total baseline ST deviation. If post PCI you have not established grade 3 flow, or pre-PCI TIMI flow grade 0, or beta blocker use delayed to more than 24 hours after MI, these patients are at high risk for late VT and late ventricular fibrillation. So post-MI, the idea is do not get lost in the arrhythmia maze. Target the ischemia directly. What Anish Bhai was emphasizing, we have to establish reperfusion. There are other factors. What has also been found is the potassium level. If the potassium level is maintained above 4, the chances of VF are less. And if you have hypokalemia in a post-MI patient, the risk is very, very high. Secondary VT. Beyond 48 hours after acute MI, acute ischemia is not directly responsible for VT in most cases. And beyond 6 weeks, generally this occurs secondary to structural disease like post-MI scar or LV dilatation, remodeling. And here ICD, defibrillator, is the standard of care. So patients who are presenting with a very regular monomorphic VT, this is scar-related ventricular tachycardia, or patients with presenting as late VT-VF with very rapid ventricular tachycardia, the treatment is defibrillator and implantation. ICD saves lives. So what do we have here? We talk about ICDs in high-risk patients. Those patients who have survived an episode of VT-VF, when an ICD is implanted, we are saying we are implanting it for secondary prophylaxis. Patient has already survived an episode of sudden cardiac arrest, sudden cardiac death, and now you are putting in an ICD to prevent death due to another episode. But another very important concept is primary prophylaxis of ICD against SCD, against sudden cardiac death. So high-risk patients who have not had an episode of VT-VF post-MI, we implant ICDs to prevent even the first death due to even the first episode of VT-VF. So that is secondary and primary prophylaxis. Secondary prophylaxis, I emphasize again, patients have survived an episode of sudden cardiac arrest, VT-VF, and ICD is implanted to save them from future life-threatening episodes. So revisiting this, VT-VF less than 48 hours, that's early VT-VF, or primary VT-VF, the target is treat ischemia, correct reversible factors. Beyond 48 hours, this is late VT-VF or VT-VF secondary to structural disease. The standard of care is ICD implantation. This is patients who have had an episode of VT-VF. And there are multiple trials. This was in 97, landmark AVID trial, where it was shown that patients who have prior cardiac arrest or unstable VT post-MI, ICDs saved lives. And in a meta-analysis again, it was shown that ICDs are much superior to conventional medical therapy for secondary prophylaxis for patients who have survived sudden cardiac death. Primary prophylaxis, patients at high risk for sudden cardiac arrest are implanted the ICD prophylactically. And ICD trials, in fact, have revealed even greater benefit of ICD when implanted for primary prophylaxis versus secondary prophylaxis. Again, there are trials right from 96, and the landmark trials are MADIT-1 and MADIT-2 for patients who have EF less than 30 to 35%, prior MI, non-sustained VT, EP-inducible ventricular tachycardia, and very recent SCUD-HEF trial published in 2006, patients with prior MI or non-ischemic cardiomyopathy, EF less than 35%. And in all these trials, except for this bypass trial, it was shown that ICDs again save lives, even for primary prophylaxis. So high-risk patients, LV dysfunction, who've not had an episode of VT-VF, these patients when implanted ICD show better survival compared to those who've not had ICD. I talked to you about the SCUD-HEF trial published in 2006. An important concept you should all know. These patients were given either placebo, amiodarone, ICD, and it was shown that amiodarone was no better than placebo in terms of reduction in mortality. So amiodarone no better than placebo, whereas ICD was superior to amiodarone. So currently, this is class 1A ACC AHA HRS guideline. Placement of an ICD is recommended in patients with ischemic cardiomyopathy who are at least 40 days post-MI. This is the other figure, 40 days. 40 days post-MI, have an LVEF of 30% or less, are in NYHA functional class 1 on chronic optimal medical therapy and have reasonable expectation of survival with a good functional status for more than 1 year. So you are not going to put it in a patient who has metastatic malignancy. So remember this, ICD 40 days post MI, EF less than 30% on optimal medical therapy. And this is the algorithm we follow. LVEF for primary prophylaxis post MI, if EF is more than 35 to 40%, just optimize medications. But if EF is less than 35, more than 40 days post MI, standard of care, ICD implantation. What about the period between 48 hours and 40 days? What is the strategy? And that question was not answered till now. So that was a lacuna in knowledge. What about post-MI patients in the interim period? 48 hours to 40 days, that is around 6 weeks after MI, at high risk for sudden cardiac arrest. If in this period of time the patient gets a VTVF, it falls into the late VTVF category and the patient would get ICD for secondary prophylaxis. No questions about it. So beyond 48 hours, late VTVF, if patient has had an episode, will get ICD implantation. But what about primary prophylaxis? Beyond 48 hours, before 40 days, high risk patient, less than 35% EF, what to do for those patients? So one of the trials which was done in 2004, look at the name of the trial, Dynamite trial. So Dynamite trial, around 600 patients, randomized to either ICD therapy or no ICD therapy, 6 to 40 days post MI. What was found was that the arrhythmic death, sudden cardiac death, decreased in the ICD group, but there was a proportional increase in non-arrhythmic death. Patient continued to die of heart failure or other causes. So there was no difference in total mortality. So death due to arrhythmias were reduced by ICD compared to conventional therapy, but all-cause mortality did not change in this period of time. And a new trial has just been published, 2009, IRIS trial, immediate risk stratification, improved survival. They categorize the patients even further. High-risk patients after acute MI, the study hypothesis will show a better survival when treated early with an ICD compared to patients receiving optimal medical therapy. And how did they include the patients? These are the patients who we are always worried about when we are treating them in our ICU. Post-MI, LVEF less than 40, day 5 to day 30, plus resting tachycardia, and another criterion was non-sustained VT at a rate of more than 150 beats per minute during Holter or ECG in the ensuing period after MI. So these patients we are all worried about. So these were the patients who were enrolled in this trial. Now this is interesting. What do you expect must have happened? This was the all-cause mortality in our control group, but even in the ICD group it was almost overlapping. In patients with EF less than 40, heart rate more than 90, overlapping. In patients who had non-sustained VT post-MI after 48 hours, ICD showed a better survival in the early period, but later on there was crossover and almost overlapping curves. So sudden cardiac death here to analyze, it was defined as cardiac death occurring within minutes after onset of acute symptoms, resulting from a documented cardiac arrhythmia, or was unwitnessed and occurred unexpectedly and without recognizable causes, for example, that occurring during sleep. The sudden cardiac death proportion was definitely reduced by ICD compared to those in the control arm, but the non-sudden cardiac death proportion again was higher, just like what was published in the Dynamite trial. So it's just a facile victory. Sudden cardiac reduction in this proportion of patients is not enough. We have to take care of a lot of other things. So all-cause mortality was no different in ICD patients compared to those in conventional therapy in post-MI patients beyond 48 hours for primary prophylaxis who have not had episodes of VTVF. So sudden cardiac death was reduced by ICD, but it was counterbalanced by an increase of non-sudden cardiac death. And during the first month after MI, in an optimally treated high-risk patient population, ICD implantation did not provide a survival benefit. So why don't ICDs save everyone from dying a sudden cardiac death? It should do its job. If a patient gets VTV or VF, ICD should terminate it and the patient should theoretically survive forever. But we have to understand, some patients die from heart failure or a large MI or asystole or pulseless electrical activity. Some VTVF may merely be a precursor to non-arrhythmic death. It may be just a surrogate marker for something else which is going on, which is much more sinister. Some VTVF presents as electrical storm, ventricular tachycardia storm, and we have a lecture on this tomorrow. So electrical storm, there may be electrical success. The ICD will terminate the ventricular arrhythmias, but overall the outcome is poor in these patients because this is merely a marker of what is underlying, what is happening to the heart underlying. So summarizing, then we are talking about primary prophylaxis in ischemic heart disease. Primary prophylaxis, again, I should say, is those patients who are at high risk for VTVF, who have LV dysfunction, but have not had an episode of VTVF as yet. So placement of an ICD is reasonable in patients with ischemic cardiomyopathy. This is class 1A indication now. At least 40 days post-MI. EF 30% or less. Even in NYHA class 1. On chronic optimal medical therapy and having a reasonable expectation of survival with a good functional status for more than 1 year. For primary prophylaxis, that is the recommendation. For secondary prophylaxis, those patients who have survived a sudden cardiac arrest, who have survived a VTVF, ICD therapy is indicated in patients who are survivors of cardiac arrest due to VF or hemodynamically sustained VT, hemodynamically unstable sustained VT, after evaluation to define the cause of event and exclude any reversible cause. This is for all patients beyond 48 hours after MI. And ICD therapy is indicated in patients with structural heart disease, spontaneous sustained VT, whether hemodynamically stable or unstable. This is class 1A and class 1B indication at present. So this is a concept that you all should understand. 6, 12 and 24 hours for reperfusion, 48 hours and 40 days for sudden cardiac death prevention. Thank you.